words, what that means technically is that the number on that previous chart that I showed you, that's something like, 40% for traditional Medicare now, 55% for MA, 100% by 2030. That's their goal. Now you might say, well, that's, it's easy for the Biden administration to say. They're not going to be in office in 2030. And that still seems like a long way off. And Mark, the numbers you showed show that these models were growing. They're not growing at that pace. Well, this was actually at least this component of their strategy was one they inherited from the Trump administration. We just did an event with Alex Azar and Nancy Ann DeParle, who were involved in these reform efforts back all the way to the Clinton administration. So there's a long trajectory. And as then Secretary Alex Azar was the one who first set these 100% goals for Medicare and just about all of Medicaid as well. And if you look at some of the policies that Trump advisors and the Trump team supported in their administration, very much in the line of getting more individuals into coordinated whole person arrangements. Some of that's through Medicare Advantage and Medicaid managed care, but the Trump administration also started the so-called direct contracting models where, at least for Medicare and for some states that want to do it, Massachusetts has a program like this for their safety net ACOs, have a direct contracting mechanism where the providers or a network of smaller providers working together, a network of FQHCs, network of primary care practices, could go towards a more full risk model themselves and just get the insurance companies a bit more out of the way. So we can talk about this more, but I'm 100% confident that whatever happens in the election, this kind of movement will continue. You might even see more state flexibilities, for example, on the Medicaid side. That, like I said, there's the Trump administration that approved our North Carolina waiver to move from fee-for-service to paying for health through managed care plans that were accountable for social drivers of poor health with financial expansions within this accountability model to support that. And the next slide, I'm not going to go through in detail, and we can make these available afterwards if you're interested. There's kind of a summary of CMS's views on what we've learned. So CMS implemented a lot of pilots over their first 10 years. Most of them didn't show savings within the 5 years of the pilot, but many of them led to learnings and insights that enabled them to be incorporated in the overall Medicare program. So CMS is still doing some additional big 5-year pilots like that. I'll talk in just a minute about some of the ones that have been announced in the last few years, since many of them are relevant to behavioral health. But CMS is also been very clear that they think they have a core model that works, and that's through accountable health plans, so Medicare Advantage, Medicaid managed care, holding those risk-adjusted capitated plans accountable for impacts on population health, access to care, and increasingly health equity. I showed you on the previous slide that one of the administration's goals is improving health equity. That's very hard to do under fee-for-service payment systems because it's so hard to get at these direct sources of inequities. And now in Medicare Advantage, starting next year, in the Medicare ACO programs like ACO REACH, there are additional payments to the health plans that are willing to take on accountability in underserved, so-called high adversity neighborhoods. They get paid more to make an impact on health outcomes and potentially through addressing social drivers and stuff like that. So CMS and CMMI are going to continue to innovate, but they're going to do it on this chassis of accountable health plans and ACO-style strong advanced primary care, with increasingly building out the supports and connections around those ACO strong primary care accountable programs. for looking ahead. And you can see examples of that as, for example, back in 2016, when there were a number of ACOs in the Medicare Shared Savings Program, the core chassis program, but not that many small and rural practices and FQHC type practices. They started the ACO investment model. That one actually showed a significant impact on improving quality and reducing overall cost by supporting small primary care practices, giving them some of the upfront investment money they needed. They incorporated that into the overall chassis, the Medicare Shared Savings Program, and now they're going further. They're kind of building on it with this primary care flex model, which is going after and trying to provide a pathway for some of the smaller primary care practices that have not yet moved into MSSP. Again, that's where there's still a gap, and they're trying to get to that 2030 goal, just as an example. Okay, so with that, let me turn to some of the opportunities for behavioral health integration. I'm going to go through these fairly quickly. This is the next slide. And then after that, there are a lot more of them today than there were, say, several years ago, because of the recognition that behavioral health really matters for improving overall health outcomes, and maybe, at least for many patients, for reducing their medical costs. Many of these are focused within further strengthening of those advanced primary care models. So why can't primary care with integrated behavioral health capabilities do more of managing patients with depression or anxiety, or managing patients with OUD who are currently stable but might need medication-assisted therapy for support, so additional payments to support that. Some of this is coming through programs like traditional Medicare's fee-for-service payments, where you may have seen, and I'm sure Mina talked about it recently at that meeting with Dan, additional fee-for-service payments for doing a collaborative care model for behavioral health, for having licensed social workers or other health professionals besides the clinicians who traditionally get paid in Medicare to have a mechanism for billing for the services they provide. What I would say, though, is that if you look at what's in fee-for-service traditional Medicare and what's in traditional Medicare through an ACO, or what's possible in the Medicare Advantage plans, basically the same model, the same payments are possible, but much more flexibility in how broad you can be with it. So limits on telehealth that apply in traditional Medicare, but it can be relaxed in advanced ACOs, those in category 3B or 4, or can be relaxed in Medicare Advantage plans within their network. And again, the reason for that is these are organizations that are not just worried about billing for specific services, but are also accountable for total costs and the impact that these services are actually having on their populations. And then I'm talking a minute about behavioral health focused accountable care models that CMS is advancing. And I just highlight that the way that we're thinking about this now is that there are a lot of other programs, federal and state, like the Texas Child Mental Health Consortium legislation I alluded to earlier, that are also providing more capabilities, more training to support these kinds of models. We need to do a better job of figuring out how to blend them and braid them together. So next slide, just a few more quick examples of what CMS is doing. One of their new model extensions of this core advanced primary care as part of ACO approach is the Making Care Primary model. It's going to be piloted in 8 states. It's notable for being a multi-payer model, so Medicare, Medicaid together, and in many of these states, employer commercial plans too. Same kinds of measures, same kinds of data sharing, same kinds of overall goals in terms of improving health, to leverage supports for practices that otherwise might get pulled in more directions. And explicitly built into this are accountability for behavioral health performance improvements, starting with measures of depression, but an intent to work with the multiple payers involved to expand that out as the program continues. Next steps, just a couple of approaches and relevant in Texas. So another new model, or pretty new model, innovation behavioral health, just getting rolling now for patients with more advanced serious mental illnesses, needing more intensive supports, moving away from fee-for-service for them to more truly longitudinal care, and also for OUD, as well as steps by CMS overall to get more accountability measures related to behavioral health into Medicaid plans more generally. What all this is getting at is on the next slide, which is a little bit busy, but it's kind of how we think about healthcare from a person perspective rather than from a provider perspective. So the next one talks about patient journey. So there's typically a lot of fee-for-service activity that can help along the way for patients at every stage, from identifying people at risk and intervening before the conditions progress, to helping them through a particular major event, maybe an OUD overdose or a flare-up in a patient's schizophrenia or other SMI. But very importantly, for many of these behavioral health conditions, chronic support. So like maintaining recovery for people who've had OUD, or maintaining control of symptoms and living in the community and being active in the community for patients with SMI. So more models are needed there, but we seem to be on the right track. And you're having a little bit of trouble advancing the slide there, it looks like. But oh, there we go. Sorry, this is the one I was talking about. And think about like what we don't have now, but we're getting to. It's the stuff towards the bottom. So we've had some small bundled care coordination payments, and like that BHI model is a whole episode bundled payment for dealing with more serious flare-ups for patients with SMI. What you'd like to do is have like this longitudinal payment going to the specialists, the behavioral health providers, other providers who are also supporting care for the patients alongside the primary care group, that reinforces and sustains their ability to engage in things like e-consults and ongoing data sharing and data infrastructure, and a true longitudinal care model that could actually be held accountable for keeping patients with OUD from having a relapse, or keeping patients with SMI living in the community and not having serious medical complications. We're still on that journey. And just next slide. Going to the next one. So this is where I wanted to mention that it's not just about funding from Medicare and Medicaid and commercial insurance that can support these models, but also some of the funding, especially for safety net support for behavioral health, that's traditionally come separately, for example, through SAMHSA's Certified Community Behavioral Health Clinics. That's critical reimbursement from SAMHSA to set up clinics that meet certified capabilities for how well they can manage patients. That's a great step. These organizations can get to better outcomes and lower costs, but it would be helpful if we could take even further steps to integrate them into these Medicaid reforms and DSH reforms and other payment reforms that can can get at the same kind of goal, instead of having just structural measures in the CCBHCs. Have measures for, at least for many of the patients they serve. Like, how are they doing in terms of functional status, preventing relapses, et cetera, et cetera. So this idea of blending SAMHSA, HRSA, other important public health safety net programs with these healthcare reforms around the same types of person-level accountability measures, having a better data infrastructure that they can share to support all of that, also something that's in process. And I think as we check the numbers, I think at this point, most CCBHCs are engaged in some kind of alternative payment arrangements with Medicaid managed care plans and other payers. I have a few more slides that I'm going to skip in the interest of time on OUD. So same issues there. We don't have good coordinated longitudinal care because we don't really do a great job providing aligned longitudinal payment supports for managing patients who are at risk of developing OUD as they go through pain episodes or other stresses. We don't do a good job. We're getting better supporting medication-assisted therapy on an ongoing basis, including in routine primary care practice for uncomplicated patients. We don't do a good job of providing add-on supports of more intensive services that aren't just about an acute treatment episode when somebody does have an emergency admission with an overdose, but not only getting them to recovery, but sustaining OUD as a effectively managed chronic condition without relapse. And there are payment models. We're working on one in North Carolina with a innovative company called Eleanor Health, and another one in Florida called Author Health, that are working on those kinds of issues under alternative payment arrangements. And the next couple of slides have a couple of examples of SUD care models. So just the last few minutes of my talking, I want to just mention a few issues for the future. So on to the next slide after this one. What are some of the remaining challenges? Well, making this even less fragmented, even easier for healthcare providers. We have standard approaches to most things we do under fee-for-service. Everybody uses the same CPT and ICD-9 codes driven by CMS setting and advancing those standards. We're not quite there yet on value-based care. We also don't have great evidence that different kinds of organizations can confidently use to go ahead and make changes. That's why I think this Project Echo approach to value-based care that you all are undertaking is so important and timely. The Healthcare Payment Learning and Action Network is really about advancing all of this with a focus on doing better in health equity, someplace that an area that value-based care didn't do that good of a job of, wasn't intentional in the early years, it's getting much more so now. Multi-stakeholder alignment, we've already talked about, and increased adoption through a combination of alignment, better supports, and more certainty, more confidence about how to succeed. And the definition of accountable care here that doesn't really talk about payment, doesn't really even use the word value in it, because again, doesn't really connect with normal human beings. They care about outcomes, they care about access, they care about quality of care, and they care about the best longitudinal coordinated experience. So that's what it's all about. The next slide, I was already one slide ahead there. So this next slide covers, sorry if I'm not showing you in advance, that's the one that I just talked about. And one more, what's the land actually doing right now? Well, it's recognizing that payment reform is only one element of effective value-based care reform. They're talking about advanced primary care, alignment of specialty care with behavioral health is a critical part of that, and then aligning community supports, especially around addressing health-related social needs and enabling whole person care. CMS is also supporting through the LAN 4 state transformation collaboratives. One of them is in North Carolina, where we're piloting a lot of these steps and hopefully can expand it out later. We also support the Accountable Care Action Collaborative, which is a very broad membership organization. That's that lower right chart that's putting together resources to help organizations with key aspects of successful accountable care implementation move along this curve from just getting familiar with it to starting out typically with a more limited shift away from fee-for-service to something more advanced and being confident about it. The next slide, the approach that we're taking in North Carolina recognizes that if you want to do multi-payer approaches, it's going to be different state to state, especially for safety nets. You have to involve Medicaid and the state-based or the federal grants that are administered through states to get those all aligned and supportive. And like I said, in North Carolina, the way we've advanced this work is not by talking about Medicaid expansion or value-based care, but by talking about what are the most important problems facing our state and the constituents of all of our elected representatives that they want to do something about. Just like Texas made a lot of progress on some behavioral health conditions, especially for kids, some big threats and some terrible events there. We've had a focus on issues like maternal health, behavioral health access, including OUD, especially in rural areas, high rates of cardiovascular disease complications, obesity, diabetes complications, and the like, which enabled us to build multiple payers, and the payers will participate if they're employers who are paying the bills, or the state who's controlling the Medicaid program, or CMS have policy pressures on them, and if those are more aligned and more effective, it makes a difference. And then implement a set of payment reforms alongside other supports, data sharing, alignment on technical issues like beneficiary attribution, learning networks to help support advancing care, and then continuing to build on that. I had like one slide in here on an example of this from North Carolina, our North Carolina Integrated Care for Kids program. Really proud of this one. Reflects with broad bipartisan support, combining data from all of our state social programs, WIC, SNAP, et cetera, and data from educational programs on which kids are participating, which kids are absent from school, et cetera, in a more timely way to share access, juvenile justice, criminal involvement programs, foster care programs to build out around individual kids and now with Medicaid expansion families to identify the ones that are at risk and to help target interventions that pediatricians are involved with. It might be a housing issue or a security, a safety at home issue, but they're connected now on data to identify the risk, programs that can help, like SNAP or housing assistance or things like that, and an effector arm through our Medicaid waiver. We have what's called a Healthy Opportunity Pilot program, where they can make a referral to a community organization, and we can close the loop and see using the linked data whether the patient or the family's issues were resolved or not. So next slide. This has really brought together a lot of different funding streams, as the next slide shows. Going to bring together social service data, health data, et cetera. We're just piloting in one part of the state now. So far, so good, helping to expand statewide. And as you might guess, behavioral health is a big part of getting this right, including kind of Project Echo for juvenile psychiatrist access called North Carolina PAL. It's a psychiatry access phone line with supporting data support and other activities. I just want to go one more slide down, three more slides down. I'm going to skip. There's some about basically this saying that this is hard. Healthcare organizations have to develop a lot of new capabilities, and in the absence of that, we don't see what seem like evidence-based, financially sustainable models getting adopted. If you go down one more, this is where I think CMS is going next, and to the extent this group is interested, would love to stay engaged with you all about like what might come after this Project Echo. So think about where support for implementing value-based care was for the last decade. It was a lot of these big pilot programs like the ACO investment model or ACO REACH, and now we're seeing episode payment models for specialty care and longitudinal care coordination models for behavioral and other types of specialty care. But we have a chassis. The harder part now to get from 30% adoption and significant but not transformative aspect within healthcare organizations to 50, 70% adoption is much more building this in at scale. And that's like a lot of how-to learning on, well, in my type of organization, if it's maybe a small FQHC that's part of a network, maybe different is what I can do next to be most effective compared to a large integrated hospital-based system where the bigger problem is probably moving away from depending on, fee-for-service type payments for major procedures and imaging. So what I think CMS is going to do more of is more rapid learning attempts. We've got better, more standardized data coming from many of these organizations that are tracking patients longitudinally. I mentioned all the steps that CMS is trying to take to improve data interoperability, reduce the burden for reporting on, say, quality measures. For example, in the ONC requirements for certified electronic health records this year, most people aren't using it yet, but there's a bulk FHIR-based API that in principle can take data from your electronic record, as long as it's CMS certified, and report out directly on your performance related to diabetes and cardiovascular conditions. And conversely, under the new so-called TEFCA program, there's a pathway for health plans and healthcare organizations to share bulk data in a more timely way. For example, building on something CMS does now in its ACO REACH program, which are timely updates on Medicare claims data, like within a day. So these are provisional claims. They include things like ADT feeds. You can't use them for exact amounts. Some of them may turn out to be wrong, but they've been incredibly helpful compared to, traditional claims feeds. An ACO program you might get as a flat file from a health plan like a month later, and it's like too late to do anything about that information. So steps like that to make it easier to learn fast. Well, can we combine that with asking the healthcare organizations that are participating in these programs, what do you need to know more about? Is it, do proposed digital tools actually work in your healthcare organization? Is it, how do you integrate community health workers in a way that's sustainable from a financial standpoint, given you're moving into an alternative payment arrangement, and there are probably things that they could do in terms of reaching patients and keeping them engaged that your traditional staff may not be able to do as effectively. What are the specific things to test? And I think you're going to see a lot more of that coming over the next few years as we try to accelerate this progress. All right, I'm going to stop there. As usual, I talk more than I intended to, but as you can see, hopefully, I really think there's some important opportunities around these topics and important opportunities to really advance value-based care. And for better or worse, I do think it's here with us to stay. And hopefully we can build on the progress that you all have made to make the next few years much more of a S-curve shape than the last ones have been.
Well, thank you, Mark. That was a great talk. Really summarized well the work that I think this group has been involved with all year. One of the challenges that practices face is that they have multiple payers that do not have alignment in the quality metrics that they need to be
Yeah.
submitting. And you had on one of your slides talked about
Yeah.
multi-payer alignments. And I know some states have been successful in getting that, but I think that's a really key ingredient in reducing provider burden as they move into value-based care. And I wonder what your thoughts are about that.
Yeah, I totally agree. CMS is doing some things directly in that regard. So, for example, starting next year for Medicaid, they proposed a set of 24 standard measures that include things like age caps and some of the NCQA measures. I think what we've heard there is that, well, okay, it's great to have a minimum set that's kind of aligned, but many states are doing more things than that or somewhat different things. How do we build out more state alignment? And that's where the work that I mentioned that the LAN is doing, combined with further payment reform from CMS, will hopefully help. So in these so-called state transformation collaboratives, like the one we have in North Carolina, it is charged with helping to adopt this new kind of next Medicare or CMS payment reform for primary care that would have the same structure and maybe not completely aligned measures, because there's some things that you want to watch in Medicaid that are not that important in, say, Medicare population, childhood immunizations, maternal health issues. But as much as possible, the same aligned measures across the Medicaid managed care plans, Medicare, traditional Medicare, and the Medicare Advantage plans, and hopefully most of the employer plans. This is a several year process because everybody's got their current contracts in place, and frankly, for a lot of private plans that still have a lot of work to update their data infrastructure to think about longitudinal supports for value-based care as opposed to fee-for-service payments and prior auth and so forth that goes along with that. But I'm reasonably optimistic that these will help. This also fits into CMS strategy for aligning quality measures nationally over time. It's called their foundational strategy, and they're planning to build in there not just a national path and roadmap to measure alignment, but also alignment of the supporting measure definitions, as I mentioned before, pathways to enable direct data feeds via bulk sampling from or bulk collection from electronic records via standard API. CMS is already doing this for some of their measures now. They need to get the other health plans to adopt the same thing, and that's what this process is about. Say, by the way, same thing happening with some efforts between CMS and CDC. In the recent proposed inpatient rule, CMS had some standard measures for hospitals to report on respiratory infection cases. That was a big pain during COVID because the data goes to public health agencies. We have, a federal public health system with 3,300 state and local public health agencies, most of which have antiquated data infrastructure, and all of which are doing things kind of differently in COVID. So there's a lot of work to report the cases and not very standard results coming out. CDC and CMS are trying to align there too. So not just getting to standard reporting formats, but also getting the public health data to meet. So if you get a CDC public health infrastructure grant now, you have to have a plan over the next couple of years to get to where you can take data in the same electronic case formats that CMS uses for its healthcare reporting, so that those two will get connected. But so there's a lot of attention, Dan, to trying to close down these gaps and inconsistency in non-standardized measures, and it's going to still take a little bit of time, but I'm encouraged by the level of attention to it. And David, you guys can just speak up. It's a friendly.
I know it's a small
I wanted to
group.
be a friendly group. Yeah.
Well, I have a lot of questions, but the first question that comes to my mind is that the national academies have defined high quality primary care as team care. Okay. And yet we still have to talk about all the different silos, behavioral health, SPMI care, and all of these things are hopefully going to kind of be submerged into an overall structure.
Yeah.
One measurement, not one measurement, but one idea of quality care and one comprehensive way to reimburse the practice. And yet we have all these billing codes and all the emphasis on COCOM billing codes and different kinds of billing codes, which keep driving separate care.
Yeah.
So there's this conundrum, and I'm just curious what your thoughts are and how you see that playing out these days.
Yeah, I know how painful that is in practices, and it partly allude to my answer to Dan, which is, there is policy awareness that we have to reduce the burden of measure alignment and reduce, everybody may want to negotiate a little bit different prices or something, but the basic model, I think there's agreement on that for primary care. It should get more advanced. It should have expectation of increased capabilities and doing more and not just managing patients directly, but in coordinated access to aligned specialists and specialty care when needed. And we're definitely not there yet, but I think we have a good chassis. And that's kind of the point of some of the slides in there about relying on the MSSP chassis, for example. That's the Medicare ACO program, and something similar in other payers. But we still have a ways to go. And I think, what is encapsulating this for me the most recently is we've been working on CMS reforming their risk adjustment systems, the way that Medicare Advantage plans are paid. It's based off the so-called HCC model. Where did that come from? Well, I was a guy who was CMS administrator when the Medicare Modernization Act passed, and had to set up Medicare Part D and the MA program. MA program, by some measures, has been successful. It's now a majority of all Medicare beneficiaries. But if you had told me then, so the question I asked at the time was, okay, what's the best data we have for identifying individual patient risk and their likely impact on cost? The best electronic data that we could collect nationally and use as a basis for payment. Prior to my being there, the Medicare Plus Choice Plan was paid essentially a capitated amount based on age and sex and maybe a little bit of geography, and that was it. And that was just not good, right? Because there's so many risks that patients have, especially those from underserved communities that just create the wrong incentives for the program. So now we're going to do a better job on performance measurement. We're going to do a better job on risk. And of course, the answer at the time to, well, what data would you use? It was insurance claims data, right? This is 2004. We didn't have electronic health records. We didn't have meaningful use, et cetera, et cetera. And if you had told me then that we'd be on version 28 of essentially this fee-for-service based payment system for MA, where not only the MA plans paid based on what this bad data, because the fee-for-service plans don't, I'm not sure they do a great job of diagnosing people with heart disease or diabetes or depression or other behavioral conditions early. But even if they don't do a good job of documenting in the claims because it doesn't matter for payment, right? The only thing that matters for payment is the fee for service, services and items that are covered by Medicare. That's what we're still using today. And not only that, if you're in MA, you have to produce encounter data, which means take your electronic records and you get guidance from this all the time from your health plans. Well, did you find out whether this patient has this diagnosis, and can you have a visit or something where you record it? That is not what people who want to go into value-based care signed up for. They want to get away from that. So I do think it's possible to get there from here, but it means re-asking the question of, well, what is the best way to measure patient risk? And I think today it's data that comes from the dashboards, the electronic records, and the social data and the patient-reported data that you're using to try to improve patient care. And I'm hoping that over the next few years, we can also make real progress on moving towards that, both for burden reduction and to actually reward, accurate data on patient risk and who's influencing it.
Well, yeah,
Maybe a longer answer than you wanted, but that's what I think. We haven't yet made the transition, but we're close.
Well, the whole idea of behavioral health is not to have a diagnosis.
Yeah, exactly. It's to have a risk
before they get there.
Exactly, and then pay for that. So, and we can actually measure that now, like who's likely. That's what we're doing in that NC Inc. program, the Integrated Care for Kids program. Big predictor of high health problems and especially school problems is unstable conditions at home, leading to foster care and patients kind of losing a home arrangement. And we're actually doing a good job now of identifying which kids those are. Now, those kids aren't expensive today, and they're probably going to be expensive next year, but they are going to have some big implications for these other state programs. So I totally agree with you. That's the goal, but we're not going to get there by using, fee-for-service claims data as the underlying core of our system. We got to modernize from that.
Thanks.
Any other questions? I know we're at the end of our session. If there are any questions, feel free to email it to me and I'll forward it to Dr. McClellan. But Dr. McClellan, thank you so much for your time today. This was an amazing session. We're also going to forward the slides in our follow-up email to you all, along with the survey link as well. So please make sure to complete those and you'll have access to the slides.
Great.
But
we'd like to hear any other feedback. And like I said, I do think there are going to be some more CMS efforts around supporting kind of a little bit more quantitative, data-driven, focused learning opportunities around questions like the ones David and Dan brought up. How can CMS pilot ways of reducing burden and doing this more effectively? So I hope we can stay in touch about all that too. Really appreciate all you're trying to do for improving care.
Thank you so much.
Thanks so much.
Have a good day, everybody.